and at 2 in the morning, you go to sleep, or it snowed the other day and you were plowing the snow because you needed to get to work.
Mm.
And that plaque has a cap and it ruptures and a goo comes out of it. And the blood cells react angrily to the goo. They just fill
Mm.
up with immediately acute clot formation, which then occludes blood flow to a beating heart. The pain feels like an elephant opened the door and jumped on your chest. And believe me, that an astute guy who knows how to palpate, and that clinical skill set is, I think, gone. But I encourage all the medical students and the residents listening to this is please make sure you listen to your heart with your stethoscope. Turns out it wasn't the patient's brain, it was the heart that was making it.
Yeah.
The heart makes hormones as well. Weight is such a key piece because at some point, at least in this country, the food industry did some lobbying. They wanted to increase their profit margins for their shareholders, right? You're the smartest doctor you'll ever find because you live in the temple. You are the
Yeah.
caretaker of the temple. Don't drink alcohol. Just don't. There's no
Safe
okay in
limit.
it. We're just trying to feed our egos. Just one glass of red wine. Don't do it. It's a chemistry experiment. You're conducting a chemistry experiment.
Hello and welcome everyone to our very special episode of the Homeostasis Podcast. Our guest today is Dr. Salman Gohar, a very good friend of mine. I had the honor of being his classmate in medical school, one of the smartest and brightest kids in the medical school, always the teacher's favorite. They always predicted he's going to do great things in life, and he proved them absolutely right. He is a cardiologist with training in general cardiology, echocardiography, nuclear medicine, as well as advanced training in heart failure and cardiac transplant. He did his fellowship in cardiology in Virginia and then advanced heart failure and transplant fellowship from Texas Heart Institute, affiliated with Baylor College of Medicine, an institute where we had the legends like Dr. Michael DeBakey and Denton Cooley that the whole cardiology world is familiar with because of their work in the fields of bypass surgery, mechanical assist devices, heart transplant. And he had the privilege of training with Dr. Bud Frazier, also a very recognized name in the world of cardiology and heart transplant. He has worked in different capacities as director and associate program director of heart failure programs at Baylor Scott and White, initially in Temple. And currently, he is working as the director of advanced heart failure program as well as the chief of division of cardiology at Baylor Scott and White All Saints Medical Center in Fort Worth. Thank you, Dr. Gohar, for taking the time out, joining us today on a Sunday evening. It's 8:49 p.m., late at night. And thank you for preparing all these slides and informational material for our audience. For people who haven't seen our podcast before, Homeostasis Podcast is an effort to educate general public regarding issues in medicine. We bring experts in the medical field who are trained, have years of experience, and they give you their unbiased, unsponsored opinion. This is not a sponsored podcast from any device company, from any pharmaceutical company, and we intend to keep it like that so people can get fair, unadulterated opinion. Dr. Gohar, thank you very much for joining us today. Thank you for taking the time out. I introduced you briefly, but I know your achievements and the feathers in your cap are much more than what I just talked about. So, if you can just briefly tell us about yourself, what you have been doing over the last 10 years, 15 years, and what are your areas of interest in the field of cardiology, and tell us a little bit about your personal life if you want to share.
Emma, thank you so much. That was very kind of you. I think it is a privilege to be here today. I must congratulate you on this effort. This is really remarkable for everybody who is watching, especially folks who want to get better and smarter about their health. Great work. As far as my background, I think you pretty well summarized this. We all have been on our own journeys using different paths and different mentors, sometimes our own colleagues, sometimes our own seniors, and sometimes complete strangers who have really helped us along the way. So my journey is no different. I came here and started off at MD Anderson Cancer Center doing research on the chemoradiation therapy on lower esophageal cancer patients, in which the heart was involved in the radiation field, and wrote on that and ended up in Virginia because my wife wanted to go to Virginia, just have a change of scenery from Texas. Ended up in Virginia, did my training there, medicine, and 1 year of chief residency, then 3 years of general cardiology, and then decided to come back to Houston, where you are. Interestingly, Texas Heart Institute is renowned, as you've emphasized, when it comes to mechanical circulatory support in advanced heart failure. Things change, but it was a historic place. You feel it in the air when you're there. So I did my training there, and then I got hired for Baylor Scott and White for Temple, Texas. Their Baylor
Mhm.
Scott and White is a big system, and it's now biggest in the country. I ended up starting off getting my feet wet as an attending, which is a completely different place. It was interesting because I wasn't looking for this job specifically where I am. I was happy where I was. In many ways, not the top guy in the program. I am just one of the worker bees, just going out, doing outreach, seeing patients, coming home, and focusing on family. And then some personal events happened, and the same job, I had seen this position where I am right now a year before, and I said, I'm not going to take this position. It's just doesn't make sense for many reasons. But then I ended up about I would say 8 months later, I looked at the same position and I said, okay, yeah, it's going to be a challenge. And it was basically coming in and starting a program. And when you start a program, you have to realize that when you go in and you look around here, there, you're looking for your boss, and you,
There's
you
no
don't have a
boss.
boss. There's no one telling you,
Yeah.
what to do. You have to figure it out, and you really have to figure out everything, the logistics, the all the aspects of what a program involves. More importantly, the people. People, we deal with people in medicine every day, so we have to understand people, and for that you have to understand yourself. So I did some training, but it was personal development, professional development. I was seeing patients and built a program and was on call for 3 years with no coverage. I had a kid in between, and so it was quite an experience, I would say, laying the foundation. But I think more importantly, when you're going out building program, you have to have a vision. You have to imagine what it is going to look like 1 year, 3 years, and 5 years. And once you have that vision, you have to have support from the really top persons in the organization. That has to be the CEO, the
Mhm.
COO. They have to facilitate your vision. They have to bring it to life. And while you're doing that, there are failures. You struggle with failures. You learn very quickly that there is no way you're going to get everything you want. And there's people that you don't get along the way, but you have to work with them. And what's interesting is that most of the time it's yourself, your brain, that's really going, and you're just psyching yourself out about things. As heart care, you have to have multiple appointments. There's 10 people you have to see. People don't want it. So that's what the hospital wanted. They wanted a VAD program. So we didn't even have a heart failure program that had the basics. So to set that up, to take small bites of what you can achieve, to recruit the right people on your team, all those things happened. We moved through that, got the program structured, did our first left ventricular assist device in the city and the county, and really ever in the whole town of Fort Worth in 2021. And then you come up with a separate issue. So yes, let's high five. Yes, we've done the first VAD. But then you need to now continue to do VADs. So that's another whole ball game. Now, how do you having those advanced patients come in, being moved through the program. So then you have to prove, because if you don't do advanced surgeries or advanced procedures, people start to forget all the nursing staff, ICU nurses. So you have to continue to do work. And then you have to go out, not only from your hospital, to do outreach. So then you recruit specialists. So you have to get colleagues on. So it's all about people power. You have to really have that skill set. So having those people come in, then they start to produce, they bring their whole skill set. And then they supplement you and then allow you to step back and think about the bigger picture. Now we have 3 advanced heart failure cardiologists here. We just did more than 25. We are going to do our 27th LVAD on the program. We have great relationship with the system. I was out recently with the president of Baylor Scott and White Heart Hospital, and they have a very ambitious 5-year plan. There's exciting stuff for us. That's where we are.
That's an amazing story. Of course, there's a lot to learn from you on the administrative side and, of course, the management side and hiring and firing process. And for people who are listening and who don't know what LVAD is, we are going to get you there in the next hour or so, starting from the very basics. So, what's the size of your program now? And what are the types of patients that you are catering to in your hospital?
So we have about 1,000 advanced heart failure patients in the practice. We're managing more than about 35 left ventricular assist devices. These are pumps that are implanted in the heart if you're not a transplant candidate. We do advanced heart failure evaluations for heart transplantation, which is not done in the hospital that I'm in. It's actually done in Dallas still. And then we have 2 nurse practitioners. We have 2 heart failure coordinators, which is a unique and very important position for those folks who are aware of what is heart failure readmission and what is the significance, especially in the administrative aspect. That's one of the top reasons for readmission in this country. Hospitals are really penalized if they don't handle that well. So we were able to get that number down in our hospital. Then we have more than 6 or 7 nurses in our clinic and MAs, and then 3 advanced heart failure cardiologists. So that is the size of the program. And within this program, there are some specialty cases: hypertrophic cardiomyopathy, cardiac sarcoid, cardiac amyloid, genetic cardiomyopathies as well. It's a relatively small program that is on the verge of growing, and I anticipate we've already grown out the space that we're in. And now we need more space because we just can't see enough patients in a day in clinic when you have so many rooms. So good problems to have, but I think there is still a lot to come.
That's a great accomplishment, building a program from scratch and expanding it to a level. So I'm sure you're proud of this. And your parents and your family are proud of what you are doing and definitely serving an area where you are desperately needed. So congratulations on doing that. Now that we have built up enough curiosity about heart failure, let's start talking about what is heart failure. And a lot of people are aware of heart attack and stents. How is heart failure different from heart attack? And why do we call it failure?
Yeah, that's a great question. I think in the Heart Failure Society of America, this has been debated. Words have power, branding, labeling, very powerful. And I think when this field started, there was this mislabeling, in my opinion, that happened with the condition. So we as a system call it now heart recovery program, because really that's it. You want to have that positive touch, because the question that we see is you treat heart failure, which I'll describe what it is, and then patients come back to you and say, if I am okay, why am I still in failure? So we try to avoid that term. I think it should be advanced cardiac recovery. So heart failure really is a chronic condition. It's like diabetes, hypertension, but what really it is, it's a state when there is an injury to the heart. Normal heart, functioning fine, suddenly something happens, and then the heart and body that is dancing constantly. You're always dancing. That was where we were wrong initially about this whole process. We thought that it was only the heart. We need to treat the heart only. There were no drugs for many years because we thought about the heart only. Turns out it has to be the heart and the body. So whenever there's an injury to the heart, there is a disruption. And if you're lucky, that disruption, the body has this mechanism of readjusting to get you through that. It could be a heart attack, it could be acute viral infection, myocarditis, it could be peripartum, it could be any injury really. And then as the readjustment happens, there's hormonal shifts, and then you come to a new state. And that state lasts for a certain time until it doesn't, because the mechanisms are there to help you acutely get through that state. But over time, you develop symptoms. And the primary symptom, and I call this a syndrome, it's a group of symptoms: heart failure or heart recovery or cardiomyopathy, really, is a group of symptoms that involve primarily shortness of breath that occurs on exertion. So you lose your vitality, your stamina, not able to do things that you were going up a hill, chasing a grandchild, lifting groceries and coming, walking through the grocery store, right? And then there are gradations of those symptoms. As things go downhill, you start getting more and more advanced symptoms. But what you're seeing is shortness of breath on exertion because the heart is unable to pump blood effectively to meet the needs of the body. And if you look at the heart is a pump, it is pumping oxygen and it's getting rid of that lactic acid, the carbon dioxide that the tissues are generating. All your cells need oxygen. So you have to have a pump that keeps that blood moving. And once that pump gets dysregulated, that whole process gets dysfunctional. You start sitting in a high pressure state. All the tissues are at high pressure. Your lungs, your organs, your kidneys, your legs, your arms. And what happens is you start having migration of fluid from the intravascular space, the blood vessels, into these tissues. And then you start having swelling. So swelling is the second symptom. But it's a typical swelling, and usually it follows more of a gravitational sort of pattern in the soft tissues, and then slowly through the interstitium, which is the extra vascular space, it goes down to your legs, and you start seeing your feet are swelling. So feet swelling, shortness of breath. And then there's some unusual symptoms. Things like you wake up at night, you go to bed, and you can't lay flat. You're having to use 3 pillows. Or you're going to bed 3 hours later, you just wake up gasping, can't breathe. And that is called nocturnal dyspnea, which is basically a sudden onset shortness of breath. The pathophysiology of that is really you're sitting at high pressure in your lungs. When you lay flat, you've got about 300 to 500 cc's of volume within your legs start to slowly move up. And as it moves up, in about 2 to 3 hours, it will push your pressure in your lungs over the limit, which will then start to fill up with fluid, and you feel there is a VQ mismatch in the lungs. And that results in hyperventilation, and you wake up because your oxygen levels start to. It is more complex, in my opinion, than that. I made it very simple, but that waking up at night, all of a sudden from sleep, can't breathe, and you have to get up, sit at the bedside, or go up, out, sit in a recliner, and you start sleeping in a recliner. The amount of times that's happening is important. Notice that. Then this chronic nagging cough that's not going away. You can't go out, do grocery shopping because you get short-winded. You went to Colorado or Murray or any hill station, and all of a sudden you just poop out. You can't breathe. Stamina, vitality, your sexual health gets affected. All these activities that involve the heart, that require the heart to deliver. And the heart's sick, it will not deliver. You will have a symptom. So then you need to investigate. Those are the symptoms. You have heart failure symptoms. You have suspicion that there's something's happened to your heart. Remember that there is an overlap, the lung and the heart. We work very closely with other cardiologists. Sometimes these patients go to 3 people, 3 doctors, get antibiotics for an infection. And it's the third guy who just, okay, let's do an echocardiogram. And the ejection fraction is 15%, 20%. And that's where how they end up in our bucket is that you end up finding that it wasn't pneumonia, it was just a valvular leak, what we call mitral regurgitation, or you just had a very weak heart and you were volume overloaded. And in a high pressure state. So that's really what heart failure is, group of symptoms. Now, how is it different than a heart attack? And a heart attack is a different problem. And in fact, I would argue that heart attack it's a very general term you throw at things. But if you ask me what is the true classic heart attack, is that there is a plaque that is built at a bifurcation of a coronary artery. And at 2 a.m, you go to sleep, or it snowed the other day and you were plowing the snow because you needed to get to work. And that plaque has a cap and it ruptures and a goo comes out of it. And the blood cells react angrily to the goo. They just fill up with immediately acute clot formation, which then occludes blood flow to a beating heart. Now that tissue is not getting blood flow and you start having pain. The pain feels like an elephant opened the door and jumped on your chest. There's pain going up to your neck. You're sweating profusely. You feel lightheaded. Blood pressure starts dropping. You may throw up. You have to automatically sit down and you can't breathe. Now that's the classic ST elevation myocardial infarction. 3 things can happen. You can die right there from ventricular fibrillation. You can be taken to the hospital and they may put a stent in by opening blood so the pain might get better, but you may have some residual scar. You may not walk out unscathed from that problem, or you may be lucky enough that you get in time, they go in, they pass a wire through the clot, inflate a balloon, get a stent in, or if you don't have a primary PCI capability, which I would be surprised, there are places that are far out, they may not have, you could get a clot buster like TPA within that time frame of 90 minutes and hopefully get that clot broken up and tissue perfusion to the distal portion of that heart that's starved, and the pain goes away, you feel better, and you avert. So that's the classic heart attack. There are other types of heart attacks.
Yeah.
There's a type 2 heart MI where you have anemia. You just lose blood all of a sudden. Pregnant ladies, they have a lot of blood loss during childbirth, or you get profound shock, septic shock, and you have blockages. They're not severe, but your blood pressure drops because and that's what you call type 2 MI. At the end of the day, the heart doesn't get enough blood oxygen, and then you have what you call ischemic injury, and then weakness, which then results in heart failure, which then rapidly overtakes the primary problem, and then you can have a whole spectrum. You can just be in full-blown cardiogenic shock, or you could just not be breathing and may need that extra oxygen using a BiPAP.
That's a great explanation. Like a great diagnostician, you preempted my next couple of questions and already answered the question about what are the symptoms of heart failure, and also what should the patients be watching out for if they're worried that they may be developing heart failure. So thanks for the explanation, and thanks for keeping it simple so hopefully everyone can wrap their head around it. Now, you did mention ejection fraction, and that's one of the terms that people who are seeing heart failure specialists and cardiologists hear a lot. And I would like you to explain a little bit what an ejection fraction is and what's a normal ejection fraction. And if you can tell us the difference between the different types of heart failure. We hear the term systolic and diastolic heart failures. So building up on that, if you can tell us
Sure.
why they're different and how they're different.
Sure. I think this is one of the most important questions of this talk, because ejection fraction number is brought up to patients a lot. And when patients come in, I ask them, so what was your ejection fraction? And they either know or nobody's told them what it is. So imagine the heart having 2 pumps, a right and a left. The lungs are sitting in between these 2 pumps. So the right pump is pulling blood from the body, all this dirty blood. I call it like high carbon dioxide, low oxygen, dark purple blood that pulls from the right side, and then this right side pumps this into the lungs. The lungs do the cleaning or washing. It's like a washing machine. They get all that carbon dioxide, all that acid out, and you get the blood filtered, clean, and this oxygen from the atmosphere goes to 21. We're right now breathing 21% oxygen. So the lungs should be capable to get enough oxygen into your blood from 21% atmospheric air to get that oxygen sat back up to 98 to 100%. So this blood turns ruby red, beautiful, bright ruby red. For those who have seen Qurbani, right? If you saw that blood spurting out, it was beautiful ruby red blood. And that's really coming from the carotid, directly from the heart, going through the lungs. But for those who haven't, spurting blood that's bright red, it's arterial. And that's a quick way of finding trauma patients. If you got oozing blood, or if it's like a spurting bright red. So this is arterial blood. It comes from the lungs into the left upper chamber. The left upper chamber squeezes it through a valve called the mitral valve into the left lower chamber. The left lower chamber opens up and fills with a certain amount. Now, I want everybody to remember that everybody's going to fill up with a different amount. A big, tall linebacker might fill up with 200 cc's. A small, petite lady might fill up with 24 cc's. It doesn't matter. That is normal for them, but we have understood by studying hundreds and thousands of patients over time that the pump on the left side should be able to squeeze at least 50% of whatever they have in them. So if it's 200 in that big linebacker, it should squeeze 100 with the next squeeze to a different valve to the body for consumption. Small lady, 12 cc's. But again, that percentage is whatever they start off with. That's the ejection fraction. How did we come to this? We can't estimate. I can't tell some patient walking into my clinic room saying, oh, ejection fractions 50. It doesn't work like that. You really have to put an ultrasound probe onto the heart, get at least 2 or 3 multiple orthogonal views, and then there are different ways of assessing, each way having its own, but there's a 2D biplane method that this gentleman, Dr. Simpson, described that looks at 2 different planes, and they almost map the inside walls of the heart in those 2 views, the relaxed state and the contracted state, and then they subtract it, the volume in the end diastolic volume minus systolic volume. So you get that percentage by that equation, and you average it in 2 views, and that's the number comes up. There are now better ways of doing that. But in simple terms, it's the heart squeezing half of whatever it has to the body, and the number doesn't go to 100. The normal heart will squeeze 100%. Because that's, oh, my heart's only 50%. It's not great. It's actually 50 to 70, and above 70 is also abnormal. Because we have to realize if you squeeze completely, then you won't have enough time to open back up. You have to squeeze enough to be, now as you're getting faster and faster because you're now exercising, that may go up. That may start to completely collapse, but it's between 50 to 70% by echocardiogram. There are other modalities. Gold standard for measuring ejection fraction is a cardiac magnetic resonance imaging, which is pretty much what we go for when there's more clarity needed. But that's ejection fraction. Now, then comes in the next question. So now we know the ejection fraction. So what kind of heart failure do I have? So they found out that when it's below 40%, that is reduced ejection fraction. When it's above 50%, and you have heart failure symptoms, your ejection fraction is 50% and more, that's preserved. But a lot of the clinical trials just did not want to include the patients between 41% and 49%.
Oh, okay.
So now you're stuck with this middle group as well.
Yeah.
And they almost always were excluded in clinical trials until recently. So less than 40% on the echocardiogram, you have heart failure with reduced ejection fraction. And it's important to know that because the clinical trials and the drugs that came out were specifically indicated and effective most of the time for that group of patients. Everybody focused on that. Heart failure, preserved ejection fraction, nobody liked that kind of heart failure for many years because just nothing worked. So now you're stuck with this group of patients that nobody really knows what to do for many years. And they're usually old ladies with hypertension and a little bit of kidney disease, diabetes. So that was a whole group. And now over the last 10 years, remarkable progress has been made. People have recognized that The middle group needs to be addressed, which is the 49 to 49%. And as they have done that, they have figured out a couple of things. Number one is you are getting better at identifying heart failure, right? So you do an echo and you see someone's ejection fraction, say 43%. This is the first echo they've had in their lives. So they may be actually getting worse. They might be getting better. We don't know, but they're somewhere on that journey. So that is labeled as mid-range EF, mid-range ejection fraction. And if we have a reduced ejection fraction, we put them on medicines and their ejection fraction goes up to above 50%, we actually relabel them as improved ejection fraction. If they're not getting better, then we still remain reduced ejection fraction. But the reason why I bring that up is we don't want you stopping your medicines, because if you stop your medicine, you'll go back from improved to reduced. Your heart demonstrates behaviors that are important to recognize, and that's why medicines are important. Now, in terms of mid-range ejection fraction, there is one class of drug that is phenomenal. It has been now indicated as a class 1 for all spectrums of ejection fraction, and that is the Flozins. They're available in Pakistan. When the last time I went there, they're cheap, they're available. A lot of diabetics are taking them. I hope they're helping a lot of people, but it really is the dapagliflozin and pagliflozin class of SGLT2 inhibitors that have now been indicated for all spectrums. Some drugs are used for just preserved, but most of the drugs that we use right now are really shining in the reduced ejection fraction cohort.
Great. And some of the people may not be familiar with the generic names. Again, we are not sponsored, but just for the ease of remembering the drugs so they can discuss it with their cardiologist. It's the class of drugs that we see on TV with the names like Farxiga and Jardiance and that group of medications. So just to expand a little bit on the imaging modalities, so you did mention echocardiogram, which is an ultrasound of the heart to assess ejection fraction, and you briefly mentioned cardiac MRI. What are some other tests, or is there anything else needed to diagnose heart failure before you can start the treatment, or this is all you need and the patient's presentation, and then you can go ahead and start the treatment process?
So there are many things we have to keep in mind. I generally do not rely on one test. I think the most important for me is the history that the patient provides. If patients come to doctors because they have a problem, they have a symptom, they want that to be addressed. And if you are unable to do that or unable to get them to a person who can, then you really, in my world, you've failed as a clinician. But I think when you think you may have heart failure or having those symptoms, you should go and ask for a couple of tests. Number one is an EKG. EKG is a pretty straightforward test. But before even we get there, I think a good clinician will be able to get some idea by physical exam alone. There are some physical examination findings that are really important. They have different sensitivities, specificities, but a lot of times when you have high pressure in the lungs, there are veins that are going on the side of your neck. We call them jugular veins. So the right side is unique because it goes straight up. It's like a manometer. And you can see the meniscus jumping up and down as you're sitting at a high pressure state. And at a 30 to 45 degree angle, if you shine a light obliquely at it, you should be able to see those pulsations all the way up. Your 3+ pitting edema, your feet will be swollen. You put a stethoscope, you may be beating really fast. Your heart rate may be above 100 beats per minute all the time. An astute physician may be able to auscultate what is called an S3. It's a vibration that happens when the upper chambers contract in the lower chamber, and that again may suggest underlying pathology. If you check a pulse like those Hakims, they would check the pulse, and believe me, that an astute guy who knows how to palpate, and that clinical skill set is, I think, gone. But I encourage all the medical students and the residents listening to this is please make sure you listen to your heart with your stethoscope as much time as you can, and pulse. Have an idea, if hopefully you have a normal pulse, what it feels. The same pressure should be applied with the same finger over and over again, so you can feel it tap on your finger. And that intensity of the tap may be different in heart failure patients. It may be louder tap, a soft tap, loud tap, which we term as pulsus alternans. Because the heart is so weak in advanced stages, it may be ejecting different volumes, 15 cc's, 25 cc's, 10 cc's. So the heart's struggling, and that translates into a pulse of variable intensity called pulsus alternans. So there are three things. If you have these three things, I can tell you there was a pretty renowned clinician, Sir Harvey, Proctor Harvey, and he had stethoscopes, Harvey stethoscopes. And he would say if you have three things, if you have those pulsations, jugular JVP, you have pulsus alternans and an S3, you can take it to the bank that you have a cardiomyopathy. There's an ejection fraction issue. So that's a clinical exam. Then you go for an EKG. EKG may tell you a number of things. You may have a rhythm problem. Your heart may be in an irregular rhythm. And your Apple Watch may be able to tell you that. You don't necessarily even need an EKG now. Apple Watches, I tell my patients to buy Apple Watches if they suspect that they're having palpitations. And sometimes the algorithm of the Apple Watch, it recognizes that this is the heart rate range, variability range of this individual. We all live in that range. Someone jumps out of that range, it will flag that, and it will try to figure out why you jumped out of that range and what time it was. Was it like 8 p.m. after dinner, or was it 2 p.m., 2 a.m. while you're sleeping? That's unusual. So it will flag it, and it will at least bring it to your attention that you may have an arrhythmia, which could be atrial fibrillation, which is important to know. And then you can go to an EKG, which will tell more critical information if you've had a heart attack in the past. There's certain signs, cardiologists would be able to easily pick it up. Q waves, blocks, T wave changes, and all that. Some hereditary abnormalities also pop up on EKGs. But then blood tests. The blood test that has a very high negative predictive value is an NT-proBNP or BNP, brain natriuretic peptide. And it basically was a peptide that initially was thought to be isolated from the brains of pigs. So it was called brain natriuretic peptide. Turns out it wasn't the pig's brain, it was the heart that was making it.
Yeah.
The heart makes hormones as well. And this hormone specifically it's special because the heart's constantly measuring how much volume's coming to it, or what we term as cardiologists, the preload. There is a curve. Frank Starling noted that if you have enough, the heart is an organ that will be regulating amount of volume coming to it. If there's a bolus that comes to the heart, it will squeeze harder until it will not. So you can stretch it to its limit, and then it will.
Yeah.
So the Frank Starling curve, preload, all of that, the heart's constantly measuring what's coming from the body back to it, and it will release hormones. The ventricular tissue releases, transcribes these proteins. There's pro-BNP, then there's pro-BNP, then there's BNP. One of the fragment, which is the NT-proBNP segment, has become more popular now because all the clinical trials are using that. And if you look at Entresto, which is the brand name, which is now Sartan, one of the main meds that at least I use in my specialty, everybody else is also using and very familiar because it was the Paradigm HF trial came out in 2014, and now it's generic in the US finally. In Pakistan and the rest of the world, I think it's been available for many years. So they made a lot of money here using that drug. People were getting it from Mexico and Canada. But regardless, coming back to the original question, sacubitril valsartan does impact BNP levels. So it actually falsely elevates that because the molecule sacubitril, it's an inhibitor. It's an enzyme that breaks down BNP. So once you inhibit it, you have actually an artificially elevated BNP level. We don't know if your BNP is really high because of heart failure or because you're taking the agent. So that's why we move towards NT-proBNP, which is not affected by it, which is the terminal propeptide. We use that. And if that marker is elevated, that is a clue that you may have a dysregulation because it is directly released. One of the questions in our boards is what is one of the cause of BNP release? And it's wall stress, cardiac wall stress. So once that stress is there, there's transcription. NT-proBNP goes to the kidneys, makes the kidneys open up and get rid of all the volume, and the heart feels better. Anti-pro-BNP, BNP level, I think that's a great also test. Troponin level, which is basically one of the molecular machinery component within the myosin, actin myosin within the cardiomyocytes. That is indicator for myocardial injury. And some patients who are not well treated or who have some issue consistently or that's persisting may have a constantly elevated troponin level. It's not very high, but it's consistently present and it has prognostic value. Those are some tests. Then you can look at your comprehensive metabolic panel, CMP or basic metabolic panel. You should be looking at what are the electrolytes doing, what is the renal function doing, because if your heart, the left side's weak, high pressure, lungs behind the left heart, high pressure, the right pump behind the lungs, then the kidneys and the liver behind be at high pressure. So now we have a congested kidney. And the congested kidney is an unhappy kidney more than anybody else. Cardiorenal syndrome is a very big entity that really has our specialties overlap. So understanding that is important, knowing what your kidney function is doing, knowing what your total bilirubin level is doing. Because as the liver gets congested, those intrahepatic biliary pathways have difficulty in getting rid of all that bilirubin that's being formed. So your total bilirubin starts to stay high. That may be a suggestion that maybe some sort of congestion is also present in the liver. So these are some tests we look at. Your iron level may be low, you may be anemic. That is another finding in some of these heart failure cases. Your bone marrow, for some reason, equilibrates to a lower hemoglobin level. But you could have other pathologies that may be driving like hemochromatosis is one other issue. So I think an abnormal blood test that should be otherwise normal should flag you to look into more testing. Then you, of course, go into a chest x-ray. I want to caution everybody, chest x-rays may not be abnormal in chronic compensated heart failure states, though they can quickly turn abnormal within minutes, which we call flash pulmonary edema. And there are certain findings on those. A chest x-ray would be also indicated as a standard test. Then you go into, as you said, echocardiogram. That's pretty much the standard of care. You want to have an echo class 1 indication if you have suspicion of heart failure or a cardiomyopathy, to be honest. Once all of those tests are done, then we can go towards advanced testing, looking for ischemic heart disease, meaning a blocked artery, which I said could present in many ways. One is a chronic slow blockage that's slowly happening over time. Patients come in with heart failure symptoms, no pain whatsoever. That's one presentation. Or they may have slow, stable angina pain that's becoming unstable as the plaque's progressing. Or they may come in with a full-blown myocardial infarction, which is also a heart attack, with ST elevations, which means that the whole epicardial blood vessel is completely occluded, meaning the coronary artery is occluded, or it may be partially occluded, which we term as non-ST elevation myocardial infarction. The urgency in that pathway will be different in that case. But at the end of the day, there are both preserved ejection fraction issues, which is called diastolic dysfunction, meaning your heart squeeze might be okay within 50 to 70%, but what we term as diastology issues, the heart doesn't relax as well, it may be too thick. So there's a lot of valuable information in the hands of the right technologist and a well-trained, board-certified echocardiographer. You can get a lot of valuable information from that study alone. I can't stress that enough. Once you go for stress testing, you can do many types of stress testing. I personally like to get patients on a treadmill. There's so much information you can get from a treadmill. The physiologic information is gold, in my opinion. Your stamina, your METs, your EKG changes, your oxygen changes, your symptoms, when they started, did they happen in recovery? What were the EKG changes that happened during peak stress recovery? Did you meet your sort of protocol threshold, which is 80% of your heart rate? And then there's the type of testing you could add to that. You can do imaging with an echo, or you could do imaging with a nuclear scanner on a treadmill, exercise exam. But if you can't exercise, then you can use other modalities such as an injection that can dilate your blood vessels, preferentially shunting or stealing blood away from the blocked arteries during peak injection, or dobutamine, which is a drug that makes the heart really contract really hard. And if your heart has a major obstructive lesion, you will feel it. You will have symptoms immediately. And then you can start to dive into the next step, which would be an invasive test. Invasive testing is pretty much someone going through your wrist or your leg and just going in, putting a catheter right at the cusp of that coronary and injecting. I think Ehtisham probably touched base on that. He's the specialist interventional cardiologist, does most of the intracoronary work. But cardiac MR and cardiac CT is matured well. We have 1.5 Tesla magnets, we've got 3 Tesla magnets, you've got 7 Tesla magnets. But you have myocardial perfusion data, you have myocardial scar burden through what we call late gadolinium enhancement. Scar tissue does not shunt. Get a contrast, you get injection, you wait for an hour, and then you reimage and see how much contrast has left the heart muscle. If it hasn't, then the pattern might help you find some clues as to what was the process. But there's other valuable information. It's gold standard. You can see valvular stuff. You can see hemochromatosis, iron deposition within the heart muscle, and stress testing using an MR as well is available in select centers. Cardiac CT, which is also called a coronary CT angiogram. It's a remarkable study because there have been new companies that have come out with their algorithms. Now this company used this special physics laminar flow assessment to measure the flow of the contrast down the coronary in across lesions to see if there was functionally significant or physiologically significance of that obstruction, and that without even getting into your body. So we want to get you into a CT scanner, get an IV, 70 cc's of contrast. It goes into your bloodstream. You feel like you've peed yourself, but it goes through your body. And the scanners, the 128 slice, they're so high fidelity, so advanced. Now there's single photon scans coming up that are assessing the blood flow in the coronaries to a very high fidelity. You can see the blood flow through the coronary, all the blood vessels. You have to have the heart rate slowed down to around below 70. With a new scan, you may not even, but of course, 70 beats or less, and then you get the contrast, you scan the heart, and then you image the inside of the blood vessels, create a map. And if there's a blockage somewhere, what we call a FFR, functional flow reserve, is measured through that proprietary algorithm on software, and you get a number. And if number is abnormal, then you don't have to go do a coronary angiogram. You could go directly to an interventionist who can then look into this was a true positive scan or false positive scan. The false positive scans, in my opinion, have been fewer and fewer as the scans have gotten better and the technologists are better and the radiologists are better. It's pretty intuitive. Good data in, good data out. So you got to be careful putting in bad data, because bad data will give you bad results, which will then result in bad decisions. So it's really important that we recognize where you're getting the study from. Go to a good center. Make sure you go to a good center that does high volume, has high caliber staff, high caliber technologists and radiologists and cardiologists. Then you can get results that you would be able to trust. Though I will say, if you need a second opinion, it's no harm getting a second opinion, especially if there's a markedly abnormal result, because then it becomes important for you to move forward, but have that reassurance that, yes, this is truly something wrong with me, and I need the invasive aspect of the studies going forward.
Thanks a bunch for going into detail on that. And it's heartwarming to hear that the old skills of checking a pulse and listening to the heart sounds are still not obsolete. They still have a value in your practice, and you're teaching the next generation of medical students and residents about it. And definitely all the potential tests that can be done to diagnose heart failure, the studies are getting better and probably making it a little bit easier to diagnose heart failure earlier.
I will
You
just
did
add one more thing. Once there's some confusion, there are two more things you could potentially do. One is going and directly checking the pressure in that vein I was talking about, jumping up and down.
Yeah.
You can just go in and directly measure that pressure. And because heart failure, you have to have what we call an elevated end diastolic pressure. both the right side or the left. We love the left side because the left is what's really pumping. That pressure has to be high to then truly confirm that you're in what we call heart failure state.
And
That's why.
the test that you do to check those pressures is called the right heart catheterization.
That's correct.
So you did mention blockages, heart attack in simple terms, as well as high blood pressure as some of the factors that can lead to heart failure. What are some other risk factors or some of the causes of heart failure that people should be aware of? And they should try to monitor or modify those risk factors to keep their hearts healthy for as long as possible.
If you look at the new American Heart Association CC guidelines, they came up with this classification system called A, B, C, D. A, I'll go to B. B is when you have a structural problem in the heart, but you don't have symptoms. You just go out, okay, I'm really concerned. I want to get my heart checked. I go get it checked, my heart function. Ejection fraction turns out to be 35%. That I would be dropped into stage B heart failure, structural issues, no symptoms. C is when the symptoms do happen and we start treatment. We want to stay in C and get out of C and back into B, meaning we have some structural issues, but we have no symptoms. We're living our life. That is what most of the people out there should be doing, being in stage B. But what you're asking is, how can we prevent? And that's where the stage A comes in. Stage A means that you don't have structural abnormalities in your heart. You do not have any symptoms. It could be all of us, right? Me, you sitting right now. Risk factors for heart failure. Number one is hypertension. We really advocate good risk factor modification. Hypertension, diabetes, renal failure over time. These are obesity, valvular abnormalities. If you've had rheumatic heart disease in the past, a rheumatic fever, you could have a valvular issue. These are all risk factors for developing heart failure. So the emphasis why that was what we call pre-heart failure, stage A, was built was to emphasize importance of treating risk factors. When patients come to a cardiologist, we want to talk to them about what's your blood pressure doing? Are you getting good enough sleep? What does your nutrition look like? What is your weight looking like? Weight is such a key piece because at some point, at least in this country, the food industry did some lobbying. They wanted to increase their profit margins for their shareholders, right? How do you do that? I can't get enough sugar canes for sugar, so let me go and talk to the guy next door who's just come up with the great genetically modified corn that grows larger, is more fungal resistant. There's going to be a lot of it, right? So now you have corn and he's doing all sorts of stuff with it. He's got a really thick syrup coming out called high fructose corn syrup. It's available readily. Let's get that and let's replace the sugar in my product with high fructose corn syrup. I'm going to have a better margin. My shareholders will be better. A lot of the nutritional changes that happened stealthily over the last, I would say, 30 to 40 years really affected the trajectory of health in this country. And then the obesity pandemic happened. With that came hypertension, sleep apnea, atrial fibrillation, diabetes, insulin resistance, all of these chronic issues, which were really key in pre-heart failure. And people just struggled with them because they were working two jobs and then they worked themselves to the ground by not paying attention or taking care of themselves and eating fast food, eating just substandard, in my opinion, diet. So it really boils down to what you're eating. You become what you eat, in my opinion. So it's so important to take control of your diet. That's where the pre-heart failure, the risk factors come up. Now, if you are already in the box of being obese, BMI more than 30, then you have to work towards getting on agents that are out there. There are some really remarkable agents out now, the GIP and the GLP-1 agonists that are really changing the landscape of obesity in this country. And you need to work on getting your sleep apnea diagnosed because your sleep apnea and poor sleep will result in uncontrolled hypertension, which will then result in heart issues. So it's all tied. It's all a spectrum. You have to listen to your body. A lot of times people are in that tunnel. They're just like working, or they're working night shift, and they come in the next day, they sleep for 4 hours, and they ate a burger, or they eat Chick-fil-A, or I'm not putting any specific vendor at fault here, but what I'm really trying to emphasize is that you don't think when you're eating, when you're hungry, when you're sleep deprived. And then you oftentimes make the wrong choices. And those choices over time, those small changes become big problems. Then you have a heart attack one morning on your way back to work, or you end up having severe hypertension and severe headache. You're in the ER, blood pressure is 220. So there are issues then eventually stressing the heart. So it's really key to read your body, to be smart. I often tell my patients that you're the smartest doctor you'll ever find because you live in the temple. You are the
Yeah.
caretaker of the temple. You need to feel it. You need to know what's going on, things that are not functioning. If there's that sound, like if you're driving a car, there's a sound happening, background, you start ignoring it, eventually it will become a bigger sound. So that's the same sort of analogy here.
That's perfect.
Risk factor modification.
So, when you mentioned the diet, is there any specific diet that you recommend to patients who are at risk for heart failure or who have developed heart failure? I know most people are aware that they need to cut down the salt in the diet, but we hear a lot of buzzwords and different types of diets being promoted: DASH diet
Right.
or Mediterranean diet, keto diet, intermittent fasting. What's your recommendation when it comes to diet and fasting and lifestyle modifications in that regard?
That's a great question. There's mixed data, right? But what you're really asking is cardiovascular health. There was a study called PREDIMED study that looked at Mediterranean diet, and there were good results. Look up the Mediterranean diet. I endorse it. Taking control of what you eat, meal planning, making your own meals, using products that you recognize as real products, what you make, trying to go for fresh vegetables, fresh meats. Those are all sort of common sense ideas. But as far as different diets, I think fasting has a role. 12-hour fasting does allow the cells to go into a regenerative state, then allows your body to heal. But then you can't just go in and have a big meal. Like during Ramadan, people actually don't lose weight, they gain weight because
Yeah.
they're psyching themselves out. They're already thinking about what they're going to eat.
Yeah. That's
That's
true.
really because that's your focus. You ate early morning, and frankly that you didn't really eat well. You just had pratas and a lot of carb loading, and then you just spend the day really fighting the urge of what you're going to eat, and then you just go for it. You should avoid that, right? Meals that don't make your blood sugar rise rapidly. Mediterranean diet is good. Complex sugars, honey is not bad, but moderation again, everything in moderation. Salt, if you don't have heart failure but you have hypertension, of course, the way a lot of the hypertension medicines are working are they're either vasodilating your blood vessels or making your kidneys pee out salt, and the water is following salt. If you have too much salt, then you're of course going to be at higher risk of having uncontrolled hypertension, which is again the main risk factor for heart failure. But that's really important. Moderation, control of what you're eating, trying to cook yourself with real ingredients, and spending time, because I consider it a very sacred act to cook for yourself because you become what you eat. So I tell patients, if I give you a pill and tell you this is going to cause hypertension, this is going to make you feel bad, this is going to make you feel slow, you will have brain fog, would you take that? No, you won't, right? Of course, nobody will. No normal person will. So same thing with meals, with food. Don't eat fried food all the time. Don't eat red meat a lot. Don't eat, in this country, pork. Don't drink alcohol. Just don't. There's no
Safe
okay
limit.
limit. We're just trying to feed our egos. Just one glass of red wine. Don't do it. Smoking, of course, you're just inhaling smoke in your
Mm,
lungs, and it's got a lot of stuff in it. Any kind of smoke over time any kind of negative habit will result over time into a negative outcome. Common sense things and moderation, and
Yeah.
trying to go for healthy options.
Yeah.
With cheat days, yeah, go for the ice cream, right? You want that ice cream every 2 weeks, go for it. You want that steak, I'm not telling you don't eat the steak, okay? Just go ahead and eat the steak, but don't eat it every day. Don't eat fried pork or whatever your diet involves that's unhealthy, that's got a lot of
Yeah.
fat. This lipidemia, these are what I tell my American patients. Now, for Pakistani patients, I'll say this: we are cooking our foods until we can't recognize what's in them.
True.
So the nutritional value, in my opinion, would be lower from all these just lightly saute food, right? Great. Chicken is better, poultry is better option than eating goat all the time, right? You go out once in a while, have a cheat day. Yes, sure, why not? But these are common sense habits that over time result in good outcomes. And that's really what I said. Everybody's going to be different. You have cultural changes depending on which part of the world you're living in. You are brought up on food that you cannot escape. You cannot escape roti. You cannot escape tortillas. You cannot
Yeah.
escape pasta if you're from Italy, right?
Yeah.
That's in your DNA. Your mom made it so many times in your house. You're just not going to, it's going to be hard. But just do the right options. There are genetic modifications to products, corn, wheat. That wheat specifically does cause a lot of GI inflammation. So make sure you know that lactose intolerance, dairy products sometimes cause autoimmune issues. Autoimmune problems over time can result in cardiovascular disease. So know your body and test out things, really. That's really how I approach this.
Perfect. I like this idea that cook your own food, because I think if you're cooking yourself, you're probably not going to cook like 7 course meal. It's probably going to be one or two things. So if you are eating what you're cooking yourself, it probably already will reduce the total calorie count.
Learn
Definitely
cooking.
applies to me.
It's a chemistry experiment. You're conducting a chemistry experiment. If
Yeah.
whoever's watching this, get that book. It's called, oh my goodness, I can't remember the name. I'll remember it. It's going to come back to me. But there's a great book that actually tells you all the reactions that happen in the kitchen, and you're really reacting things. You're
Mm,
braising, you're boiling, you're frying, you're broiling. All these are reactions, but their timing, what ends up result was to what, how much, what kind of egg, how much hardened. It's called Food Lab. Kinji is, I think, the author. Food Lab. It's a big book. I encourage your listeners to go and look it up and have
definitely.
it and just go through the pages about
Mhm.
how fascinating it is to prepare a meal and
Yeah,
eat
that
it
definitely.
while you're happy, because whatever feeling you have, whatever energy state you're in, you will actually put that energy into the meal. You will not
Perfect.
be patient. You might, if you're angry, you're making meals, you're making chai and you're angry, you're going to boil it too much, or you're going to
Too
be
dark.
happy when you're cooking.
Yeah.
That's the answer as well.
Thank you very much for sharing that. So I think I'm going to ask you a couple of more questions. I don't
Yeah,
think we can get through all the questions we have
sure,
today. Mashallah, your knowledge is just, you're just brimming with knowledge, and I want to imbibe as much as I can. I don't want to cut anything short.
sure.
And this is something that is definitely going to be very helpful to our audience. So I think the questions about the treatments and your expertise about the ventricular assist devices and heart failure and
Right.
artificial heart, I think we'll need one more session with you if you are kind enough to
Sure.
give us some more time. But we'll just finish with the questions about prevention and the risk factors and some lifestyle modifications,
Yeah.
and then discuss the more fascinating and high end stuff in the next session. So, question about exercise. What do you tell your patients regarding exercise? Patients who are dealing with heart failure, taking the medications, they already feel a little tired. What's your recommendation to them? What's the target? Or is it just whatever you can do is fine?
It all depends on case by case basis. Someone who's coming in a walker, they'll be limited to what they can do. But I'll tell you, any amount of exercise is better than no exercise. What is exercise? That's such a broad statement. And there's so many of them out there, right?
Mhm.
And I think it's interesting because I'm going to stoke some controversial stuff here, but honestly, I
That's
do think
perfectly
that
fine.
I think the gyms are ripping people off. I think they are because there's been studies that have shown that you get all these people, they've got like 2,000 members and there's 200 machines. And they know the equation. It's all about it's a psychological game. Start of the year, and then people just pay, but they're not going to work. So they're just paying someone.
Yeah.
So I have to be cautious as to what and understand, and I have to relay that to patients because in a doctor patient encounter, I don't know about you, Ahmed, but I do get a sense that if I've connected to the patient, has the connection been made? If there's
Yeah.
no connection, I can throw the kitchen sink at the patient, tell them that they won't listen, really. They won't. They just won't. That's the reality. You have to have the trust. Once you have the trust, then you have to do common sense stuff. So, for example, where you are practicing matters. So, for my patients, if you go by the book, 30 minutes walking 5 times a week, total of 150 minutes. That's the recommendation. Walking. You can go faster. You can, I don't advocate jogging. If you want to jog, go ahead, do it. But as you age, your knees and all that, depending on what surface you're running, you will eventually have other problems. But if you are able to go to a gym 5 times a week and incorporate it as a habit, like a pill, it's a pill you got to take every morning. I have to go, I've got to do it 30 minutes of my day, make it a habit. It takes 21 days for all those listening, 21 days to going to the gym to make a habit. And then you go on a vacation and it goes out the window. So I'm telling you, the gyms have it all squared up. So what I'm really telling you, find your neighborhood, go walk 20 minutes, 30 minutes, brisk walk, go play tennis, go play a sport that you enjoy. Not golf, though. Not golf. Okay. Golf is not that much of an activity. You want to have something that makes
Your heart
a
rate. Yeah.
moderate exercise. That is what the recommendation is.
I
Moderate
see.
exercise, 30 minutes, 5 times a week, total of 150 minutes. You can space it whatever you want. That's my recommendation. Stay active because movement is life. It most importantly builds your cardiovascular health and stamina. And if you're not active, if you have symptoms, by the time you have symptoms, it's already quite late. So exercise allows you to gauge if you have heart failure coming up because you will be doing, say, I was walking 2 miles every day. I got a viral infection. I was next to my granddaughter and I had this upper syndrome. And 3 weeks later, I can't do the 2 miles. There's clearly you have that change that you can measure yourself in. So that's really helpful. Staying active will allow you that opportunity versus if you never were active and when you were short of breath, your heart's already quite sick because now you're short of breath at rest.
Yeah. That's very useful advice. I think the way I think about the gym is the $100 you're paying the gym is the $100 you can't use to eat food that you might have tried otherwise, the ice cream or a good steak at a decent restaurant. So at least
Right.
you're reducing the calories.
If you can and you can do it, all power to you.
I think I've wasted a lot of money on the gyms. I could never go there more than a couple of times a
Yes.
month. I have the feeling that these home gyms or home exercise machines like Peloton or Tonal or anything that you have staring in your face every day might be a little bit better than a gym that you have to drive to and get dressed and be there at a certain time of the day and then it closes after a certain.
Use that you enjoy every day that is has some exertional aspect to it. That's my best advice.
Yeah. And for people who get scared after hearing about the diagnosis of heart failure, now you call it cardiac recovery, I think that's a great idea, not to scare the people, but can they still live a full, active life, or they really have to cut down on things that they like to do? Just for someone who's listening, who's dealing with this, what's your kind of forecast for their future?
Yeah, they can absolutely. I want to emphasize though that not all types of cardiomyopathies are the same. So some are more severe than others, some require special attention. But in general, if it's because of ischemic heart disease, if you had coronary obstructive lesions, you had stents, you had a bypass surgery at some point, now your heart is weak, you have scar, it's not going to recover, Doing rehab, doing lifestyle stuff will really help you and live the quality of life that you want. Seeing your doctors, being on the four known proven therapies for heart failure with reduced ejection fraction, you can absolutely live a life of quality. Every case is going to be a little bit different, but the answer is yes. We live in a good time. We live in a better
Correct.
time than what we used to 10, 30 years ago.
And is heart failure reversible, or once you get diagnosed, it's a lifelong condition and you just have to deal with it for the rest of your life?
I think I would say that once you have it, there's been a structural issue with the heart. It is just the way it is. And the sooner you get over that realization, the better you can take care of yourself. So you have a cardiomyopathy, a structural issue with the heart. You took care of it. You're on medicines. You're doing well. In general, most of these issues, especially if there's scar formation, they stay with you for the rest of your life.
I see. And what role can family physicians, primary care physicians, or general practitioners play in diagnosing heart failure earlier? What do you see getting missed in practice that you wish people were not ignoring or missing? And the patient comes to you and you feel like, oh, it could have been diagnosed earlier or it could have been treated earlier, and I could have done a better job at making this patient feel better.
I think that's a key type of physician that is pretty much the front line, the first person that ends up in seeing these patients. I would encourage all the primary care docs to have heart failure or cardiomyopathy in their differential diagnosis, especially for shortness of breath, for these recurrent infections that you're using antibiotics and you're not getting anywhere, cough that's not getting better. Ask pointed questions. I think the meat is in the history. And any smart physician will be able to get an idea that there's something that's going on that may be involved with the heart. There are unique circumstances, such as right heart failure, such as hypertrophic cardiomyopathy. These are unique presentations, but they're fewer. Myocarditis is another unique presentation of heart failure where there's inflammation that involves the heart. So, history, and if there's any suspicion, do two things, actually three: EKG, an NT-proBNP level, and an echocardiogram. If they're abnormal, you have it. You have the diagnosis. Then the next step is, what is the cause? Is it ischemic heart disease? That needs to be number one. We need to go ahead and assess the coronaries for some way or the other. And then you go over the list, which is a number of things that could be issue going on in terms of arrhythmias, genetics, viral cardiomyopathy, toxins, all these things.
And for people, especially the younger kids these days, the teenagers, the adolescents, people in high school and college who want to experiment and try different things at least once in their life to get the experience, what are some of the things that can hurt you even if you are using them for a short period of time when it comes to heart failure and heart health? What are some of the things that you say people should never even touch in their life if they want to stay healthy from a cardiologist's standpoint?
I will say be smart. You get one temple. This is your temple, you're its caretaker, right? And we all have this sort of gauge. I know it's hard to imagine someone who's 16 years old or who's 18 years old. They just want to experience stuff. I will say that be smart, really. Protect this body. Cocaine, amphetamine more specifically, not marijuana. Marijuana is not as bad, in my opinion, but meth, cocaine, alcohol, tobacco, vaping, stay away
Mm,
from all of those. Just don't do it.
yeah.
And the reason being is, why do you want to get into that box of heart failure that you cannot get out for the rest of your life to start off with? So don't put your heart under stress. They're very well documented toxic effects of cocaine, methamphetamine, anabolic steroids. Young guys want to use to get that extra oomph in the gym. Too much steroids can result in heart failure as well, and it's oftentimes irreversible. Alcohol, direct toxin, over time builds up. And again, you end up in advanced heart failure, then you need a heart transplant or an LVAD, and that's not a good place to be. So, a common sense approach, really, that's what I advocate. Have mentors, find mentors in your life that are successful, physically, health-wise. Ask them questions. Try to emulate them. Stay away from wrong company because you really will take over the energy of that company.
Yeah.
So stay away from bad folks who are involved in this. Find people who are driven, who have great ambition, and who also have success in their personal, their physical, their professional lives. So that's really what I tell young folks is things that I wish I would have somebody have told me, not that I didn't. We're always growing, we're always learning, and it's never too late.
And you need mentors at every age. Even at our age, we need people who can tell us what to expect in your late 40s or early 50s or how to grow your careers. Let me ask you one more question, and you can give a brief answer or explain as much as your ATPs allow. And then we will stop here and move on to our next session whenever we meet the next time. What are the first line medications used in heart failure and how do they work? So you can
Right.
give an expanded answer, a brief answer, and we can pick up from where we leave next time.
I will just focus on because I have always given you broad answers, but I'm going to just zero into this. Look at the ejection fraction. If it's reduced ejection fraction, you should be on four meds. You should be on one of these four classes, really. Heart failure, beta blockers. There are three beta blockers that have been shown in clinical trials: carvedilol, metoprolol, succinate, and bisoprolol. Three. Then you go into the next class, which is the angiotensin receptor antagonism and angiotensin converting enzyme inhibitors, or what we talked about, sacubitril valsartan, which really is the drug of choice, which is brand name Entresto. That is not attacking the heart directly, but it's attacking the body's response to heart failure. A remarkable agent, definitely improves quality of life, longevity of life. Third is SGLT2 inhibitors. They make you urinate. So the sugar, water follows. There's a diuretic effect. Some salt follows as well. There's some hypothesis that there's some regenerative pathways within the heart and kidney, which you know very well, that result in remarkable improvement in symptoms. I think there is about 16 days. 16 days, you start feeling better. So it's a unique agent. You want to lower the heart rate with a beta blocker. You want to dilate the blood vessels. You want to get some volume off and introduce regeneration through the SGLT2 inhibitors. And then mineralocorticoid receptor antagonism. That is multiple trials, spironolactone, eplerenone, and now there's a non-steroidal agent coming out called finerenone, approved for more than 40% ejection fraction. Now studies are looking at less than 40%, but these agents have been shown to improve myocardial recovery, fibrosis reduction through actions that are unique. There are some side effects that we all know and we should be aware of. But in any case, these four classes for heart failure with a reduced ejection fraction, you have up to 73 to 75% reduction in mortality, relative risk reduction, and hospitalizations. That's it. Once you're on the drugs, you want to go up on the doses, go up to the highest dose you can tolerate because it's dose dependent as well. So you start, if you can't go up, you have symptoms, you go drop to the lower dose. Doesn't matter if you don't have any symptoms, you still want to try to go to the highest dose. That's where the heart failure guideline directed medical therapy clinics are coming up. So that's reduced ejection fraction. Preserved ejection fraction, you have class 1 SGLT2. You have class 2B, the mineralocorticoid receptor antagonist, spironolactone. You can use those. Entresto for hypertension, optimization, risk factor modification. I have started to use more and more GLP-1 agonists as well as GIP. The dual agonist, I'm moving towards tirzepatide, which is the dual agonist. Now, there's a triple receptor blocker also coming in, retatrutide. But we are seeing a significant, in my at least assessment, there are receptors in the brain and the gut that are being stimulated, but there's also some direct changes in the adipose tissue that people are losing weight sitting there watching TV. So they come back, they're down 20% of their body weight, and all of a sudden preserved ejection fraction phenotypes or the heart failure varieties are feeling great. I tell them, let me give you two 20-pound dumbbells. Now walk around, you just lost 40 pounds. Tell me, how do you feel? So that's the remarkable attack on obesity that I think is very relevant in Pakistan, in the Pakistani population. Pakistani population is unique because we do not necessarily follow the BMI as a risk factor. We have the waist to hip ratio, which supersedes that because we have this different type of bodies. South Asian phenotype has been now deemed a risk factor, like hypertension. Just being from that region, you have a risk factor for cardiovascular disease. So
Yeah.
we really have to focus on weight loss, and we have a different type of genetics. So this is really the drugs that I would use and try to go up on the highest doses that you can.
Thank you very much for your time. I know we still have a lot to cover. Like I said, it was a fascinating session and I learned a lot. I'm sure our audience learned a lot. We will get into some more details. I know you have some slides and some data that you want to share with us. So hopefully, we'll have more time in our next session to look at that data and then get into the fascinating world of the artificial hearts, mechanical devices, and heart transplant for patients who do not respond to the medication. Thank you very much once again for giving us your precious time. I know your time is worth thousands of dollars. You are doing it just for, I guess, for our friendship's sake and for education's sake and for your love of medicine and to educate the public. It's free of cost. Again, like I said, no sponsorship, no money has exchanged hands, no bitcoins transferred. So it was all a public service message. Appreciate your time, appreciate your depth of knowledge, and it's always fascinating to know where our colleagues are. Of course, we have seen each other face to face after, I think, about 19, 20 years. So it's always good to see old friends and see how remarkable they are doing in their careers and how they're serving their patients. Anything else you want to say before we say goodbye?
Thank you.
And hopefully meet you next time.
For a great podcast. Thank you for having me. I enjoyed it. I've enjoyed your prior interviews with some of our other class fellows. So keep up the good work. And I'm looking forward to talking more.
I appreciate you. All right, everyone, you take care. Stay tuned for our next session with Dr. Salman Gohar, the advanced heart failure specialist, when he talks more about all the fascinating stuff that's happening in the world of cardiology and heart failure. Goodbye for now. Take care. Allah Hafiz.